Hello and welcome to ASNC's interview series number 13. This is Burning Questions for Technologists, and we're hoping that this reaches other people that are involved in the lab as well. My name is Erin Stevens. I'm a nuclear medicine director at Oregon Heart Center in Salem, Oregon. I will be the lead interviewer. I have Russell Sterling with us, that is my co-interviewer, and Tim Dunn is our expert. Russell, do you want to go ahead and introduce yourself? And then Tim, you can introduce after Russell.
Sure. I'm Russell Sterling, and I'm the chief technologist at Wellstar Healthcare. It's in the Metro Atlanta area, and I'm over the nuclear and MRI program here.
I'm great. My name's Tim Dunn. I'm the technical director and chief technologist in nuclear cardiology and cardiac PET at Maine Health Cardiology, way up here in Scarborough, Maine.
All right, Tim, first question I have for you. There have been quite a few big advancements in recent years for myocardial imaging. How do you feel the new technologies such as PET and CZT are impacting imaging as we know it?
That's a great question, Erin. Thank you. I think, as we know, PET is cardiac PET's revolutionizing our field. It's introducing so much more information in what we get from our studies. The resolution of the studies is so much better than SPECT. And then when you factor in adding the myocardial flow reserve and being able to calculate rest and stress EF in real time, it really is a game changer in how we diagnose coronary disease and treat our patients. You know, if you have it available, that's the big thing, is having it available. I'm blessed to have lab that we have both the cardiac PET CT and the CZT camera. And one of the great things with the CZT camera is it's a lower cost piece of equipment to buy. The image resolution to me is phenomenal. I would argue it's better than some of the SPECT systems I've seen. And the images are fast. So we're imaging our patients on a lot faster time frame. And with that, we have a lot less motion, a lot cleaner images. We have patients that are much more satisfied, and it's a very small footprint camera that those patients that are claustrophobic don't have a problem with it. So in both instances, I think it's really advanced our field greatly, not only in access with the CZT cameras, but with the quality of imaging with both of them. I think they've both really stepped it up, and you know, it's not available everywhere yet, but I feel in the future it will be. Thank you.
Yeah, I can really appreciate what you're saying about the CZT with the quality of images, the smaller footprint. I agree with all those things. Do you think there's still avenues for to pursue advancement in labs that maybe can't afford the newest equipment?
Oh, yeah. Thanks, Russ. Great question. Yeah, definitely. I mean, here, I'm lucky. We just opened this lab up 8 years ago. We moved, but before we moved into this lab, my old lab had two SPECT systems, no CT. There's two dual headed. One was a very old system. We still produce top quality images. When you get the chance, you know, the option to do prone imaging on these patients. So not having a CT, although advantageous to have CT, if you don't, you can still do prone imaging. Your images might take a little bit longer, but if you've got good technologists, and adherence to good quality control and following the guidelines, I can't express this enough. We have guidelines through ASNC and the IAC that help guide you right through ensuring that you're producing high quality diagnostic images and that you're still providing the highest possible patient care that you can. So not having the ability to, or the funds to buy a PET CT or a SPECT CT or whatever, you can still, and we have been for years providing high quality images with the older systems. Thanks. Great question. I mean, I think a recent study by ASNC or survey was less than 50% of those surveyed had hybrid systems. So there's a lot of people out there without a hybrid system.
Yeah, I agree with you, Tim. I don't have a hybrid system on my SPECT camera, and so I feel like the technologist is a really big role in getting good quality images. So, you know, on that question, as a technologist, do you feel like being able to produce good quality images is the most effective way to make these changes that will give the best quality possible and still be in the best interest of the patient? Or do you think there's a different avenue, you know, while we're pursuing this advancement that is the most effective?
No, I think as a technologist, obviously you have to work with what you have. And advocating to your administration for advancement in imaging equipment is, I think, critical, because our administrators don't know what they don't know. You know, they don't know that there are more advanced systems out there, and that, you know, systems get dated, get older, they get close to end of life. Now, as a technologist, I think it's imperative that you do the best job you can with what you have. And I mean that by, if you don't have a hybrid system with CT, then you're carefully looking at the image, which it should be anyway, and recognizing if you need to do a prone imaging on that patient, have that patient return after a delay, to have to clear some gut activity out of the way. But again, also dealing with your administration and your physicians to try and budget for advanced imaging equipment down the line.
Got it. Yeah.
I hope that answered what you're asking.
Yeah, it does. It does. Because sometimes these facilities don't have a lot of options and you're trying to advance as much as you can with what you have. Yeah.
Right.
So on that question, Tim, on that response, when working to implement imaging of new disease states or advanced technologies, how do you fit them into an already packed schedule?
Oh, Erin, a great question. And we've had that happen in our lab. And as many of you are aware, especially with the new popularity or increase in especially amyloid imaging, PYP, and labs that don't have PET, the volume, our PYP volume here has gone through the roof. I mean, we were doing one every few months. I'm doing 4 or 5 a week.
Wow.
So what we've had to do is take one of our slots, our injection slots, we can say, for our regular sesame stresses, and that becomes a amyloid injection slot. Just the schedule is scheduled into that slot, and then with our EMR system we have, it allows us to have the patient come back and pick a slot 3 hours later. So we're not trying to fit them in around other patients. And we're very busy. I mean, we are booking out a couple of weeks, but these are very important. And, anybody that watches TV and you're going to see the ads for the for amyloid drugs on there, and it's driving the popularity of this study through the roof. And in the same aspect, when you're looking, if you have a cardiac PET system as well in your lab, the increase in or the number of sarcoid images that I'm doing patients now has gone again. A couple of years ago, we'd do 1 every month. I'm doing probably 15 a month now, almost 1 a day. And we've had to do the same thing in that. We've had to just, it's tough because the organization wants us to do as many PET perfusions as possible. But, we have to take a slot. We book our PETs in 45-minute slots. So we take one of the slots for the resting injection, and then injecting the FPG, and then we take another slot for the imaging later on. But it's challenging because, institutions or facilities want them not most of them. They want maximum volume, but they also want you to do these non-routine type of studies that don't fit into your typical template. So I think it's also important. I mean, and it's tough. This gets to be a touchy spot with some technologists. Is advocating for yourself and having administration, your lab understand you can do these procedures for them, but you need to have adequate space to do them, not only for patient quality, but patient care and patient safety, which have to be most important. Hope that kind of sums up basically what we do here in our lab.
I like that, Tim. I feel like you're kind of making a pivot towards more patient care focused instead of maybe numbers focused. So, how can a technologist or even like a lead technologist build a team focused on patient care?
Well, that's another wonderful question, Russell. Thank you. It takes a couple of things to begin with. Number one, you need to be your team's advocate if you're the chief technologist, but you also need to have a good leader with you. Your medical director that you work with has to be your advocate, has to stand their ground and saying, understand that we know volume's an issue, access are an issue, but patient care and patient quality have to be number one. And, it's happened before in labs, our lab, where the pressure's on to do more. We want more patients through. And it gets tough, and it's hard for technologists. I don't understand that. It really stands your ground, but you need to, because you're the last line of defense for those patients. Your administrators aren't there, so if they're asking you to do more and it's not safe, you have to say no. And, we have done some restructuring in our lab where we changed our scheduling template for the pet access because we were backed up. But we did a pro forma. We showed that we needed a dedicated provider in the pet lab and a dedicated cardiac tech to go with the new tech. We could do that volume. But for patient safety and patient quality, we needed to have those parts in place, or we couldn't do it. And again, I'm reiterating this, but it really comes down to being your own advocate for your team and making sure that your medical director is right there standing beside you to ensure that most important patient quality and care come first.
Yeah, that's a great point, Tim. It's really important to have that, to advocate for yourself, but also advocate for your teammates, because that's what you are. You're a team helping with these patients. So yes, I agree with that. Last question I'm going to ask you, we're going to kind of pivot into something different. So I've noticed some hospital labs turning away from focused accreditation instead of leaving labs with a blanket JCO or DND. How does this impact nuclear cardiology labs?
That's a wonderful question. It irks me. I have been part of an accredited lab for 24 years. I've done the accreditation. If you leave a lab, in my opinion, if you leave a lab to fall under a blanket umbrella of a Joint Commission accreditation and not utilizing like an IAC accreditation, I'll use them for example, you miss out on a lot of things, because the IAC, not only are they interested in your equipment, but they drive quality. They have the guidelines for reporting so that you're actually getting everything you need in your cardiac reports, whether it be a MIBI or a PET or whatever it is. The guidelines for quality control and quality initiatives, which are imperative, because you could be the greatest lab ever. If you're not doing quality control, looking at what you're putting out, you're really not. Being accredited, they hold you accountable for everything that you're doing. And I don't personally think, I think it's a mistake to go away from an accrediting body and just going under a blanket. And I think it just leaves you too vulnerable to start to slip in your quality. And then by doing that, you start to compromise your patient care and what your patient quality and your whole lab, the quality of your whole lab can suffer.
Yeah, I said it pivoted, but it actually came back around to everything that we've talked about with patient care.
Yeah.
Number one thing. So having an accreditation helps with that. That was great. I think we had a great discussion, Tim. Like,
Oh, thank you.
loved all these questions that we asked you. It's been a great discussion.
Thank you very much, Erin and Russell. It's been great talking with you guys as always.
Yeah.
Yes, of course. Yeah. I feel like the big takeaways I had from this are, how new technology is changing the face of nuclear cardiology for the positive, and what can labs do to make improvements if that newest equipment is out of reach, and also how each lab can make a positive change when it comes to standard of care using the schedule, relationships, and education.
Mm-hmm.
I like it.
Yeah. I think one of the big takeaways is that you have to work with what you have.
Mm-hmm.
And as we all know, there's a big push for dose reduction and speeding up imaging and stuff like that. So you can make improvements on older equipment. There are third-party vendor software that you can install that is relatively inexpensive that will allow you to do half time, half dose. I used to do that a few years ago on some of our older equipment. Utilizing prone imaging on non-hybrid systems, taking what you have and optimizing your equipment in your lab to produce the best quality that you can is the biggest thing, and that comes from the technology standpoint. That's them working with what you have, and then always advocating for potentially at some point getting newer equipment. You might not be getting be able to hop right into a PET, but eventually, advancing up to a spec CT or something, or more advanced imaging.
Yes, thank you for
that. So I think we got some really great points, Tim, from this interview. And Russell, thank you both for being a part of this. And I want to thank ASNC for giving us the ability to have an interview like this and get it out there for techs and people that work in the lab with them.
Thanks.
Yes, thank you.
I got one final thing, and thank you, ASNC, for giving this opportunity. But to all the techs out there, remember you're the first line of defense when it comes to your patients. So you need to be there and be their advocate and make sure you provide good quality for them. Thank you.
Thank you.
Thank you so much.